We can go ahead and get started. It's my pleasure this afternoon to welcome actually two speakers and presenters to our Grand Rounds Forum, Dr. Lee Ryan and also Dr. Richard Lane. Starting with Dr. Ryan first, she received her PhD in clinical neuropsychology at the University of British Columbia in 1992. After that, she moved to the University of California, San Diego as a research scientist and joined the U of A faculty in 1996. She is an associate professor in the departments of psychology and neuroscience. Her research utilizes magnetic resonance imaging studies to evaluate memory and aging, and risk for Alzheimer's disease. Our second presenter is Dr. Richard Lane, who has been on the University of Arizona faculty in our department since 1990 and is professor of psychiatry, psychology, and neuroscience. His research has focused on the functional neuroanatomy, psychology, and peripheral physiology of emotion and the relationship of emotions to health. Dr. Lane has also been the director of our psychotherapy curriculum over the past 20 years, and today's presentation reflects his efforts together with key collaborators to apply new knowledge about the brain basis of emotion and memory to our understanding of how psychotherapy works. I should add that neither speaker has anything to disclose that would present a conflict of interest in presenting the topic for today, and the topic is entitled Memory Reconsolidation, Emotional Arousal, and the Process of Change in Psychotherapy, New Insights in Brain Science. And we'll start first with Dr. Ryan. Dr. Lane.
Thanks, John, and good afternoon, everyone. It's a pleasure to give this presentation today with Lee Ryan, who I've been collaborating with for over a decade in the fMRI program here at the University of Arizona. There's actually a third author of this presentation, who is Les Greenberg, who is the creator of emotion-focused psychotherapy. Les is from Toronto and happens to be at South Africa at the moment, so it'll just be Lee and me today. Leslie and I wrote a paper with the title that you see on the screen that's been submitted for publication. It's been under review now for 6 weeks, so we're anticipating getting the reviews back very soon. But the three of us are excited about this paper and wanted to share our ideas and get feedback from a broader audience of clinicians, hence our presentation today. And this is actually the first time that Lee and I are presenting this publicly. We're particularly interested in knowing whether these ideas make sense to you and whether you find them clinically useful. So the outline for the talk is that in the first part, I'll address the question of why we need a theory of change in psychotherapy. I'll talk about a couple of implicit mental processes, implicit memory and implicit emotion. And then I'll conclude by summarizing what we think are the essential ingredients for change in psychotherapy. Then in part two, Lee will talk about memory reconsolidation, the neural basis of emotion-memory interactions, and tell you what episodic and somatic memory are, and how to distinguish between them, and why they're important for psychotherapy change. And then I'll wrap up with some implications for clinical practice, research, and education. So why do we need a theory of how psychotherapy works? And I'd emphasize the word how, because there are over 500 different kinds of psychotherapy. Some of them work, some of them don't. And a lot of the psychotherapy research involves examining whether or not the therapy works, but how it works, if it does, is a different question. And that's the kind of process research that's starting to be done. If a therapy works in general, we want to know exactly how it works or what the essential ingredients are, because maybe we can improve it even further and make it more efficient. We know, for example, that in psychodynamic psychotherapy, there have been progressive changes over the past century, and maybe this could be more empirically guided. Another important question is what should be taught to physician trainees in psychiatry. We're in the process of reviewing our psychotherapy curriculum here in the Department of Psychiatry, and we're starting to ask what is really essential to be taught. Now, the best evidence-based therapy, or the therapy for which the most evidence is available, is CBT. But that just tells you, does CBT work in general? It doesn't tell you if it works for the specific patient. And it also doesn't tell you, even if it does work for the specific patient, is that the best therapy for this patient? So we then come to this next question: how do we select which therapy to provide for a given patient? And we would argue that if we really understand how therapies work, we should be able to make such decisions. We're not yet able to do that. The next question is, can we understand the neurobiology of change? Well, if we can characterize change psychologically, we have the potential to then measure it neurobiologically. But part of the motivation for this synthesis that we've come up with is that we're trying to take neurobiological factors into account from the get-go, essentially. And then maybe by doing so, if this seems psychologically plausible, then we'll be closer to actually getting neurobiological measurements. And lo and behold, if we could do that and use objective measures to predict who will respond to a given therapy and to choose therapies, we're not nearly there yet, but if we were to get there, we'd be on an equal footing with other areas of medicine. So we're trying to cover broad territory here, but one of the important distinctions between the major modalities of therapy is whether recall and reconstruction of the past is really necessary for change. Psychodynamic psychotherapy is the predominant model that we use in our Department of Psychiatry. And that model holds that remembering and reconstructing the past is essential. It's also true that new experiences in the therapeutic interaction are essential also. But it's really critical to know that remembering and reconstructing the past is not essential for a number of major modalities that have good empirical support. So behavior therapy, such as the systematic desensitization, involves exposing someone, for example, to a phobic stimulus, generating the arousal, and then recovery in a safer environment, but in the original problematic context. That does not require that the person figure out where that problem came from. Similarly, CBT involves identifying episodes of distress and what the thoughts were that preceded the distress and changing those thoughts. But again, don't have to understand where that came from, earlier in childhood, for example. Same is true for emotions-focused psychotherapy. The goal is to have more adaptive emotional responses in problematic situations, but Les Greenberg really firmly believes that going back into the past and understanding where the problem came from is not necessary. So with regard to the psychodynamic model, I think an important organizing principle is that of the corrective emotional experience. And Franz Alexander and Thomas French wrote about this in 1946, and I think we still use this today, because they said the corrective emotional experience was a fundamental therapeutic principle of all etiological psychotherapy. That is, psychotherapy that's trying to get at the causes or the original origins of the problem. In their definition, this meant to re-expose the patient under more favorable circumstances to emotional situations which he could not handle in the past. The patient, in order to be helped, must undergo a corrective emotional experience suitable to repair the traumatic influence of previous experiences. Intellectual insight alone is not sufficient, but they truly believe that intellectual insight was necessary, and you also needed to have an emotional experience, a corrective experience with the therapist. So we might say that, thinking about these modalities that I mentioned so far, that these are the essential ingredients of change in psychotherapy. There needs to be emotional arousal. There needs to be a cognitive component, a kind of new learning of some kind. And it could be that remembering the past might be an optional ingredient Okay, so we're talking about emotion and cognition, somehow bringing them together in the service of therapeutic change. So how do we understand how emotion and cognition work together? Well, we're very strongly influenced by the work of and writings of René Descartes, who lived 400 years ago. And he's responsible for Cartesian dualism, mind-body dualism, because he said that the mind was associated with thought, and that was connected to the soul and to spirituality. It was uniquely human, shared with God, didn't have a physical presence or extent, whereas emotion was associated with the body and was in part of the material world and was shared with animals, whereas thought was shared with God. So there are two very different domains, and we've traditionally thought of them as very different and, well, incompatible. Now, it's taken 400 years to realize that this distinction is really in error, and Antonio Damasio wrote a seminal book in 1994 pointing out that when we understand the neural basis of emotion and cognition, we realize that they're kind of inseparable in the brain. Okay, so that's one important point. But another important point is that when Descartes talked about thought, he was talking about conscious, rational thought. And when he was talking about emotion, he was talking about conscious, what we call feelings, or experience of emotion. And modern cognitive neuroscience has really altered our thinking about that, because we now realize that the vast majority of cognition is actually implicit or unconscious, and that conscious cognition, conscious thought, is just the tip of the iceberg. And I will argue that we're discovering that a lot of emotion takes place outside of conscious awareness, and so there may be more similarities there as well. But when you remove this association with consciousness, then it's almost impossible to figure out where to divide between cognition and emotion. And so this book that was published 10 years ago with colleagues from the psychology department here, published by Oxford University Press, we argued that if you define cognition as information processing, there's nothing about emotion that isn't cognitive. The distinction between implicit and explicit processes is foundational in cognitive neuroscience, and I'll argue it applies to both cognition as well as emotion. It was first demonstrated in the case of memory. So explicit, conscious, explicit or declarative memory, conscious recall of facts and events, is mediated by the hippocampus, medial temporal lobe, diencephalon, and other structures. And this is Lee Ryan's expertise. She can tell you more about that. In contrast, there's non-declarative or implicit memory, which is learning skills and habits, priming, simple classical conditioning, non-associative learning. And the point is that these implicit memory processes are mediated by different brain structures than explicit memory processes. So skills and habits mediated by the striatum, so that even people who've had their hippocampus removed bilaterally and cannot recall events in their lives still can learn skills. And they won't remember that they learned it, they won't remember how they learned it, but they'll still demonstrate behaviorally that they have learned new skills. And this distinction may apply to emotion as well, the distinction between implicit and explicit. Well, what is emotion? That is, I would say that emotion involves automatic assessments and adaptive responses to changing circumstances. We believe that emotions emerge during mammalian evolution to enhance adaptation to the environment by learning from experience. We think that's why we have limbic systems and amygdalas, to learn from experience. reptiles only respond reflexively and can't learn from experience. Emotional responses are initiated by an automatic assessment, often implicit and unconscious, of the extent to which goals are being met in interaction with the environment. So when you feel happy, it's because you've evaluated that something good has happened in the environment. You don't necessarily consciously think about, oh, is this good or not? Oh, yes, okay, now I'm going to feel happy. You don't. It's automatic. Emotional responses also involve a concomitant automatic resetting of physiology, behavior, thought, and feeling to enable the organism to adapt to changing circumstances. And I would say that the physiology and behavior part is kind of the foundation for emotional responses, and that we might call implicit. And when you add the feeling part, that's the explicit part. So how do we know that there are implicit emotions? Well, we have this structure, the amygdala, in the medial temporal lobe. And this cartoon shows a man encountering a snake in the forest. That information goes to the lateral geniculate nucleus of the thalamus. And then there's this low road pathway directly to the amygdala to set off that threat response, which includes a behavioral somatomotor response and the visceromotor response to that threat. Okay. Then there's this high road conscious pathway, and you can determine whether or not it's a snake, if it's a dangerous snake, or it might be a piece of rope. But once that implicit unconscious representation goes to the amygdala, it will set off that defense or threat response. And this idea that there are such things as unconscious emotion are now an accepted part of academic psychology, and that's because there's empirical support for it that can be demonstrated in carefully controlled experiments. So you can use a technique called backward masking, for example, where you present either happy faces, neutral, or angry faces, very briefly, for less than 30 milliseconds, so 16 milliseconds here, and then followed by a neutral face, so that all you consciously perceive is this neutral face. But then it can be shown that the type of face that was presented to the subject will influence their behavior, such as the consumption of a novel drink. So they might drink more with a happy face and drink less if it's a threatening face. Okay? And they don't realize why they're drinking more or less. Okay? We can extend this idea of emotionally driven behavior to more complex kinds of behavior, which we'd call emotional procedures, or the doing of emotion, the behavioral component of emotion. Emotional procedures are rule-based schemas for how to do things that relate to emotion, such as how to express love, how to handle anger, how to get attention, how to joke around, how to obtain love and reassurance. This is stuff that we learn as kids from growing up in our families. And I'll say more about that. Emotional procedures are activated whenever emotions are aroused. These procedures often serve an emotion regulatory role, such as avoiding embarrassment or shame, and they're learned and refined implicitly during development and are executed automatically, and they become deeply ingrained because emotional procedures are repeated in different contexts, and families select which procedures are permissible and which are not. Mom and Dad tell us what's okay and what is not okay, and we learn pretty quickly. And so these procedures reflect how self and other are expected to behave. And once established, these procedures are resistant to change. And I think that's very much related to the kind of intractable problems that people come to psychotherapy looking for help for. So Robert Kleiman, in this paper in 1991, psychoanalyst, said that various psychotherapeutic phenomena can be reconceptualized as emotional procedures. So transference, for example, can be thought of as a procedure in terms of how one acts in relation to other people based on how one interprets the other's actions. So patients often come to psychotherapy because they're unhappy with aspects of their social or occupational lives. They're typically unaware that this is part of a behavioral pattern triggered by emotions that they ignore or are not aware of. This behavioral pattern is typically manifested in interpersonal situations that are reminders of problematic situations from the past, transference being an example of that. And the problematic response to these situations consists of behavioral patterns that are the procedural expression of emotion activated by the situation. So people are stuck in these implicit patterns. How do you get out of it? And that's where we have the wonderful work of Les Greenberg, I think, to thank, because he's not only conceptualized it, but also done a lot of empirical work to support these ideas. Why do we ask people to tell us how they're feeling and to put their emotions into words? This is Les's answer to that. And he's written 20 books on emotion-focused psychotherapy. And this, by the way, is my favorite slide in all the psychotherapy teaching I do, because it's so fundamental. You have an emotional response, and that induces a bodily feeling, what he calls a bodily felt referent. That's the lived story. That's what we experience. And then we have people put their feelings into words, explaining how they're feeling. This is the told story. And importantly, this is a mental representation of experience. And that mental representation, importantly, has a bidirectional relationship with felt experience. It changes how you feel, and then that feeling becomes a substrate for further mental representation, conscious processing. But it changes the conscious experience. So this is our proposal for how automatic implicit emotional processes can be altered. Reconsolidation of emotional memories. Previously unformulated adaptive emotional responses, such as experiencing anger for the first time in relation to a traumatic event from the past, can be experienced in psychotherapy and put into words. These emotions are experienced in relation to the problematic situations from the past and become added to an expanded narrative of the problematic situation. So memories of these old problematic contexts that incorporate these new adaptive emotional responses can be reconsolidated, so that putting new scripts and emotions into words enables them to be understood and rehearsed until they become automatic. So we're going from the implicit to the explicit, involving conscious experience and maybe even understanding what the pattern is and how to make different choices, and then doing it over and over again until it becomes automatic or implicit, kind of like learning how to drive a car with manual gear shift, where you have to learn how to do it, but then it becomes automatic. You don't have to think about it anymore. So we would say then that these are the essential ingredients for change in psychotherapy. We need to activate old memories and old feelings with or without awareness of their connection to the past. You need to concurrently engage new emotional experiences that change old memories through reconsolidation, which Lee Ryan will explain to us in just a minute, and then reinforce the strength of these new memories and their semantic structures by practicing new ways of behaving and experiencing the world in a variety of contexts. So with that, I'll now turn it over to Lee Ryan.
Well, it's interesting that Richard was talking about these three components of experience: emotions, memories, explicit memories, and what I would call semantic structures, or these implicit procedures and knowledge about the world. In a very old way, actually, from a cognitive neuroscience point of view, that they're very separate from one another, that explicit memory is really mediated by different brain structures. Here's emotions over here. They're very different than what we talk about when we talk about semantic structures. And so what I'm going to give you a little hint about right now are just three pieces of evidence, recent things that have happened in cognitive neuroscience that are changes to that idea. And they suggest to us very strongly that all three of these components are actually far more interactive with one another than we would have expected from before. So I'm going to just give you some empirical examples of three things. One of them, this very strong interaction of emotion and memory, and what emotion does to memories. And then I'll talk about a relatively new theory of how memories are built and what happens to them over time, called multiple trace theory, that I've been very involved with in terms of looking at various predictions that it makes and doing empirical research on that. And then I'm going to talk about this last piece, that episodic memory, so your ability to remember events from your past, and these semantic structures, these things that we use to predict how the world should be, how we need to act in the world, are very much more interactive and connected to one another than we thought before. Maybe not for an amnesic, somebody who has severe medial temporal lobe damage, but in the normal case, which I'm assuming that the majority of the patients that you work with are relatively normal in that way. For the majority of us, these things interact very significantly with one another. So first of all, emotion and memory. We know that these two systems are very strongly interactive. The things that you remember throughout your life tend to be the things that happened to you in the past that are very emotional. And by the way, most of them happened when you were 20, and then it's downhill from there. You don't remember much more after that, turns out, as you get older. But we think about it as because a lot of very important and very emotional experiences happen in those formative adult years. A difference, and this is really because of these two interacting brain structures, the hippocampal structure and the amygdala, and these two systems and how they are integrated. A difference recently is in how we understand how stress generally kind of drives memory. You know, if you think about a lot of the things that your patients may talk about in psychotherapy, generally these are stressful events. They tend to be pretty negative events. They have a lot of negative emotion attached to them, and they have a very negative sort of physiologic arousal attached to them. And we used to think that stress was just simply bad for memory. You get stressed, and you're not going to remember very much about what happened. But it actually turns out that that's quite different than to what really does happen. So let me explain a recent study from my laboratory. This is with undergraduates. This is not truly traumatic events, etc. We're not allowed to do those kinds of things to our undergraduates. So here's what we do. We bring them into the laboratory, and half of them, we give them a very stressful situation that they have to live through. They have to give an impromptu speech to a set of judges that are standing in front of them, wearing white coats. They're hooked up to different things that are monitoring their heart rate, etc. And they're being judged on the quality of the talk that they're giving. They're also being filmed at the same time. This is very stressful. These people are sweating, they're red in the face, their heart rate is going bananas. They're really very stressed by this. And in comparison to that group, we have another group where they are engaged in a very interesting task, but it's not stressful. And then right after they've finished that stress-inducing procedure, in this experiment, we've done this in many different ways, but in this experiment, we give them two different slideshows, one that tells them a story, a very emotionally arousing, very negative story about this one was a bad car accident with somebody gets a severed leg, all kinds of stuff. And then one that's a neutral story as well. And unbeknownst to them, they're going to come back to well, they know they're coming back to the lab a week later, but they don't know that they're going to actually have to remember what they saw in the two slideshows. And then we ask them to remember all of the details. And what happens with stress, this is recall over here, and this is recognition. Doesn't matter how you test them, you see the same patterns. So the black bars are the individuals who are stressed. And what you can see is that for the emotional story, they remember more of the emotional content. And they actually have a deficit in remembering the neutral content within this single episode. Whereas the non-stressed individuals, there's a little bit of benefit for emotional material. We see this across many, many studies that we've done, but it's not significant actually. I don't know where this thing's here. So they're remembering They're actually remembering a sort of unbiased view of what happened during that event, whereas these individuals who are stressed are focusing on the significant emotional components of that event without actually being able to recall the more kind of neutral or other aspects of the context of that event. So it shows us that stress is not only important because of the emotional response, but it's having an impact on actually what we attend to, what we encode, what we learn about events, and what we remember later on. So being in a stressful event means that an individual later on, when you ask them to remember that stressful thing that happened to them when they were young, they will focus on the more emotional components, not only because they choose to, but because they probably never really engaged in the more kind of neutral components of the event at all. So you end up with a representation of a memory that is biased significantly toward the emotional content. The other thing that Richard and I have talked about a lot is the role of the hippocampus in what we call consolidating memories. And let me explain why this is important. The old version of what happened with a memory, like one of these emotional memories that we were just talking about, is that you experience an event and you have some memory for that event, and for a short period of time that memory will undergo a process of what we call consolidation. So it will become stabilized somehow within the brain. But after that consolidation process is finished, then the notion was that memories were, that was it. Memories were stable. That's the way it was laid down. Now you have a perfect record of what happened in the past. You may not always be able to retrieve it, ideally, but the record stays there and it's stable and it's not malleable. Now what we think is actually happening is that every time you retrieve a memory and you think about it, you recall it, that hippocampal process of consolidation comes online again. Essentially, as you retrieve the memory, it comes back into this fragile, malleable state, and so it can be messed around with by new experience. This is called multiple trace theory, and it was put forward by Lynn Nadel here in psychology and Morris Moscovich at the University of Toronto. The first paper was 1997. And it's really changed the way many people think about how memory works. So I'll go into it in a little more detail. So here we have our hippocampus. I make it really big because I love the hippocampus, and it's so important to me for memory. And we know that what the hippocampus is doing is it's acting in the early stages of the memory, of the event memory, as a kind of pointer, so that it's connecting together all of the components that are represented in various neocortical structures that have been engaged during the original event. And so this is kind of the pointer, the basis of the true representation that is connecting to all of these various components of the event. So it's an indexer in this case. Now, as I mentioned before, the old version was that over time, these things become connected directly to one another as consolidation happens, and that these ones down here, these little arrows, would simply drop off, and you no longer need the hippocampus. And so now what we think is something very different. That indeed you have that original index within the hippocampus that is pointing to those components, those neocortical components, but when you retrieve the memory again, you now bring online a new process of consolidation within the hippocampus, and at that point you are able to actually integrate new information into that, and that's being represented here by these little green dots, so that you have the original event, but you are also integrating new things that have happened in the context of the recollection. So the place where you are, maybe updating the information, somebody tells you, no, that's not what happened, this happened instead, and you incorporate that into the original event. Now, two things about this, two predictions that this MTT theory makes. One of them, that I'm not going to talk about too much except just to mention it, is that this notion that the hippocampus doesn't just go away, that it is always important for the recollection of events, no matter how old they are. And so in 2000, I did a study in my laboratory with fMRI, and we actually had older adults come into the scanner, and we had them recall very old events from their past, so 20 years, 30, as many as 40 years ago. And what we saw was that, in contrast to what we expected from the kind of classical view of the hippocampus, was that the hippocampus was very active during the recollection of those very old events. The second thing that it is suggesting here is this notion of integrating new information, so that as you are recollecting this old experience, doesn't matter how old it is, that as you are experiencing something new in this context in the combination of recollection, that you are actually able to change in some fundamental way the original representation of the event. So this is a critical point for understanding, I think, what's happening in during the experience of psychotherapy. That the corrective experience is not only laying down a new memory and a new experience, but in a fundamental way, it is therefore changing prior experiences and your recollection of those prior experiences. That's a very, very different way of thinking about memory, and it has some, I think, important implications for how we think about psychotherapy as well. Oh, and just to show you one piece of data that shows you how easy this is to show, this notion that when you recall a memory, that it becomes fragile, that at that moment you can integrate new information into it. So this experiment, this has been done many ways, so I'll just give you an overview. This is actually from Lynn Nadel's laboratory here at U of A. So in the first session, there's 3 sessions here. First session, subject comes in and you give them some stuff that they have to remember. It doesn't matter what it is. They've done it with lots of things. Objects, stories, lists of words, doesn't matter. And then in the second session, which happens 2 or 3 days later, the subject comes for another experiment. And they actually don't know that it's tied to the first experiment that they're doing. In that second experiment, some of the subjects are given a subtle reminder of what happened in the first session. So it might be that it's in the same room as it was before. For some subjects, it's in a different room, but it's the same experimenter. Or it might be something like, if it's objects, you show them the same basket that the objects were shown in before. But there's no direct request for them to remember what happened before. It's just a reminder. And then you get them to learn some new stuff. And then another 2 or 3 days later, you bring them back for the third session, and at that point you ask them to remember what happened in the first session, whatever the stuff was that they learned in the first session. Make sense? Okay, so here are the no reminder groups. So these, they're remembering a lot of information from the first session, and they intrude virtually nothing from the second session. Those 2 sessions are separate. They're separate memories. And here is the group that has a reminder. So they also remember much from the first session. But look, now they add in about 30% on average of the material that they learned in the second session. So they have, just because of that simple reminder, it doesn't have to be consciously recollecting at all. It's a very small change in an experimental paradigm, but you are changing, bringing online, what we think is happening is you're bringing online that memory in such a way that now new information is actually being incorporated into it. And you see them giving you that information, thinking that it's part of the wrong experience. So the psychotherapy experience, not all, as Richard said, but many modalities of psychotherapy engage in this process of remembering prior experiences. There's a reevaluation in some cases. There's certainly this notion that goes across pretty much all of psychotherapy of some sort of corrective experience. And what we think is that not only are you giving people new experiences, but you are changing fundamentally then the way that they recall and that they represent prior experiences as well. I'll mention one other thing, and that is this interaction between semantic structures and episodic memories. I was glad that Richard put that slide up. It's a very old slide showing here's episodic memory over here, and here's semantic or declarative memory over here, and there's no connections between them. So we learn stuff about the world. We learn how to predict the world and knowledge of the world and habits and procedures in one way, and here's episodic memory, and the two things never interact. And this really has undergone a significant change in the last 5 or 6 years, a lot of it because of the work actually from my laboratory, showing that in the normal case these areas interact significantly. And what we see is that, in fact, the hippocampus is very much active in the normal individual when you're doing even the most basic kinds of semantic tasks, and vice versa. So let me give you an example of this. So I'm a neuropsychologist, and probably the classic semantic memory task, the pure semantic memory task that we would use when we're assessing someone with a brain injury or amnesia would be category production. So I ask you to tell me as many fruits and vegetables as you can think of. Right? So you don't have to think about anything from your past. You just start saying apple, orange, blah, blah, blah. It's what you know about the world. So what we did in this experiment was we had subjects come in. Again, they were undergraduates. And the day before they went to the scanner, we took 12 categories, and we made them learn lists of exemplars from each category. And there were relatively unusual items. So they weren't things like if in the category animals, it wasn't dog, cat, mouse, etc. It was lion, elephant, rhinoceros, etc. So relatively atypical exemplars. And they had to learn them to perfect repetition the day before. Then when they came to the scanner the next day, we tested them in 2 different ways. We asked them to recall the lists from the categories that they learned the day before. That's clearly episodic memory. But we also gave them 12 new categories, ones that they hadn't seen the day before, and we just asked them to come up with the first 7 items that they could think of that belong to the category. That's the classic semantic memory task. We expected, based on old thinking about this, that in the remember condition we would see lots of hippocampal activation, and that we would see nothing in the produce condition. And I wouldn't be telling you this if it didn't turn out differently than that. This is a little wrong. So these are the produce conditions on the left and the right. I've circled the hippocampus in case you don't know where it is. Here's the remember condition, and I've circled the hippocampus. And it turns out that in every medial temporal lobe structure, when people are producing semantic memory, you see just as much activation in the hippocampus, if not more, than when they are actually remembering the episodic list task from the day before. I was very curious, obviously, about why this happened, and this is really fascinating. So I was glad that I did one thing in this experiment. We asked subjects to tell us what they thought about when they were doing this semantic memory task. And here's what they told us. So 100% of participants said, when we said, what were you thinking of when you told us about kitchen utensils? And they gave us some form of this. I pictured myself in my kitchen opening drawers, and I named the items I saw there, and then I looked around the room and saw what else was there. If I asked you to come up with items that are in a garage, tools, every one of you, I guarantee, would actually experience that you're standing in a garage. And it's not just any garage, it's your garage. It's your own experience of your own autobiographical self. And you're utilizing that information to access semantic memory. We've done these experiments in many ways now and in different populations, and we see this strong interaction in the normal case that episodic memories and semantic structures are inextricably linked. So what we come up with is a little schema here of what we think now. Instead of having these three things, episodic memory, semantic structures, and emotions, being completely separate from one another, but what we understand now is that they are really interacting in very fundamental ways. So that if you access in psychotherapy via memories, you have the ability to change emotional responses and semantic structures. In CBT, we might start by emotions and go to semantic structures, but we are fundamentally then changing prior experience as well. These things interact and they change one another. I think it's a nice way to think about the basic changes and what is common across all modalities of psychotherapy. And so I'll let Richard talk a little bit more about that.
Thanks very much, Lee. So I'm only going to review a couple of these slides. I want to leave time for discussion, and I'm going to skip a couple of slides. But I do want to go through this one, implications for psychodynamic psychotherapy. So we talked about the centrality of the corrective emotional experience. And I think the modern work by Dan Stern, who is a psychoanalyst in Geneva, Switzerland, is very relevant here because he's pointed to the intersubjective reality that goes on moment by moment between therapist and patient. And this is a kind of implicit process in the sense that it may be part of consciousness, but it's not attended to or reflected upon. But it affects the ongoing course of the therapy. Occasionally, something unexpected will happen, a critical moment in the psychotherapy. And often this involves when a problematic transference expectation is not met and an important new experience occurs. And so when people think about what really mattered in their analyses, it will be key moments such as this. And I would say that this fits with our model of strong emotional arousal in the context of old memories and then perhaps getting reconsolidated. If that's the case, then we have to think about the phenomenon of having people lie on the couch as the sine qua non, an essential component of psychoanalysis. Marianne Goldberger, a psychoanalyst in New York, points out that you can do psychoanalysis by sitting up, and in fact that might actually be preferable because there's so many missed opportunities for new emotional experiences that are lost if patient is lying on the couch, not seeing the analyst, and the analyst is relatively silent, okay? And this may help to explain why some analyses are unsuccessful. If most of the time is spent recalling and reliving old experiences without having new experiences, then you're just reinforcing the old memories and not changing them. Okay, I'm going to skip these two, and you have them in your handout, and you can ask questions about that. If a theory is useful, it should generate novel predictions. So here's a novel prediction that I don't think anyone has thought of before, but it falls directly from the model that we proposed, which is that rapid eye movement sleep is known to preferentially support the consolidation of procedural and emotional aspects of memory. Now, clinically, we pay special attention to sleep disturbances in various conditions. So if someone is manic, one of the first things we do clinically is try to medicate them so that they get to sleep at night, and that's a significant achievement if people are able to sleep. Similarly, depression associated with sleep disturbance, we like to see that improve with antidepressant therapy. Well, might improved sleep actually facilitate change in psychotherapy? We don't typically think of it that way in terms of its reconsolidation of memories, but that might be the case. How could one test that? Well, maybe people should take naps after a therapy session, and maybe therapy will be more successful if people take naps associated with REM sleep than non-REM naps. That might help consolidate the new memories, particularly if there's an especially meaningful thing that happens in the session. Okay. What about medical education? Right now, residents are required to learn various modalities, but how do they learn to apply one modality or another for a specific patient? Well, here's one way of thinking about this general model and how it might apply. For behavior and exposure therapy, perhaps this applies to specifically identifiable situations that elicit the maladaptive response. CBT and emotion-focused therapy might be for symptomatic syndromes that are temporary disturbances in emotional responses, such as clinical depression, but are not situation-specific. And maybe we might reserve psychodynamic insight-oriented psychotherapy for enduring trait characteristics that are neither temporary nor situation-specific. So to conclude, therapeutic change in a variety of modalities, we believe, results from the reconsolidation of emotional memories by incorporating new emotional experiences in contexts that are reminiscent of the original problematic situations. Change in psychotherapy, therefore, has three necessary ingredients. One, activate the old memories, including the old feelings. Activate new emotional experiences. And then practicing new ways of experiencing the world in a variety of contexts. We believe that this new perspective has implications for, as we've said, clinical practice, research, and education. And very, very interested to know if you think that's true. So thank you very much for your attention. So Lee and I will be happy to take questions.